Hi, I'm Sylvie from HR.com, and I'll be your webcast host today. Welcome to Providing Quality Benefits for Employees with Cardiovascular Disease and Other Chronic Conditions, sponsored by AIMED Alliance and Alliance for Patient Access. This webcast has been pre-approved for one HRCI and one SHRM credit. Please be sure to attend the complete webcast in order to receive your credits. If you have any questions during the webcast, please type them in the question and answer tab on your webinar controls. And it is now my pleasure to turn you over to today's presenters.
Thanks, Sylvie, and good afternoon, everyone. Welcome to today's webinar. I'm Stacy Worthy. I'm counsel to AIMED Alliance, and we're joined here today by Kathy Berra, co-director of the Life Care Company, Dr. Ryan Gossel, vice president of IBM Watson Health, Ryan Gooch, the Executive Director of the Partnership to Advance Cardiovascular Health, Alan Cole, President of Total Wellness, Lindsay Videniak, Manager of the Cardiovascular Working Group, and John Wylam, Staff Attorney for AIMED Alliance. So we'll start off today with an interview with a practitioner to learn about cardiovascular health. We'll provide an overview of health benefits and access issues, a discussion of the economic burden of cardiovascular disease, review some data from a recent study, discuss cardiovascular health in the workplace wellness, and then we're going to end with a Q&A. Just a little bit about AIMED Alliance. We're a nonprofit health policy organization that seeks to protect and enhance the rights of healthcare consumers and providers. And I'm now going to turn it over to Lindsay.
Thank you so much, Stacy. Again, my name is Lindsay Videniak. I am the working group manager for cardiovascular disease for the Alliance for Patient Access, which is a nationwide network of clinicians like Kathy Berra, who we're going to hear from today, who care deeply about patient access. And so, Kathy, why don't you just give a brief background about your work?
Thank you, Lindsay. I'm happy to do that. It really is a great pleasure for me to participate in this really important webinar. My background includes over 30 years of research and clinical practice at the Stanford Center for Research and Disease Prevention, predominantly focusing on the prevention, primary and secondary, for cardiac and other vascular diseases. In addition, I spent a number of years in a very busy cardiology practice dealing directly with access on a daily basis. So it's something certainly dear to my heart. And in addition to that, I am past president of the American Association of Cardiac and Pulmonary Rehabilitation and past president of the Preventive Cardiovascular Nurses Association. So that's my background. And again, it's my pleasure to be here.
Thank you, Kathy. Next slide. Next slide. So we only have about 10 minutes for our discussion. So Kathy, I wanted to start off by hearing from you about the real scope of CVD and its effect on covered lives. So talk to me about some of the figures we're seeing on the screen and why it really means that, we talk about heart disease being the silent killer that we ignore at our peril.
Absolutely. It's my pleasure. We're all at risk for numerous chronic illnesses. At the top of the list are cardiac and other vascular diseases. In terms of it being called a silent killer is because often your first knowledge that you have cardiac or vascular disease is sudden cardiac death. About 50% of people, that's either their first introduction to knowing they have vascular disease is death, or hopefully being admitted to a hospital where they can be managed probably with unstable anginal symptoms. So we're all at risk. It starts young in our life and proceeds progressively throughout our life. Of course, the biggest risk is age. All that said, younger people and young families can be at risk with certain conditions such as familial hypercholesterolemia, which I know we'll be talking about more in the future. We need to focus on risk factor reduction along with any kind of medical intervention. So what we do with our lifestyle is key to our ability to be successful in preventing disease.
So chances are the folks on this call are going to see employees who are experiencing this disease state, and in order to have a healthy workforce, trying their best to make sure that folks can make sure they have the treatment options and the ability to manage their disease. So next slide, let's talk about that prevention versus the break and fix approach, right? So we know, and you just mentioned, that prevention is always cheaper. It's, and for many, heart disease is entirely preventable. So, your first course of treatment, I think folks would agree, is usually proper diet and exercise. But can you talk about that, and then talk a bit about what it means for those patients who really may have a genetically high cholesterol, or they might have to take other tacks in order to manage their disease?
Sure. I think it goes without saying that living with a chronic, serious, major illness is difficult for everybody. It's difficult for the patient, for their family, their friends, their working community, their social community, and everybody involved in their life, as well as them. Certainly, it's a huge burden. So it's really imperative that we have very strict guidelines and very important guidelines to live by. Diet and exercise are first line of defense, even for those with other problems such as familial hypercholesterolemia. Even though their LDLs are extraordinarily high, they still benefit from diet, physical activity, weight loss, cigarette smoking cessation, etc. So we need to know our patients well. Anybody that you see with an LDL of 190 or greater, and I kind of use a little bit of a lower end cut point, say 160, should be evaluated for other causes of LDL evaluation other than poor diet and lack of medications, period. Statins become very important early on in patients with FH. However, there is well-known statin intolerance and needs to be dealt with other non-statin medications. So the complexity of the treatment is very clear, but it's so important and it does work. And I think the ischemia study that just came out recently at the AHA showed that primary prevention and secondary prevention do work, but it is an ongoing process and it's a team-based intervention.
And, we're going to hear from folks later on in the webinar about why having, the ability to access more treatment options is better than fewer treatment options. But it just seems like, it's the right course of treatment for the right patient at the right time. Could you talk for a minute about that and how important it is for those patients?
In terms of those patients with the high LDLs?
Yeah, and making sure that, there's not sort of a cookie cutter approach to this, I would think.
Absolutely not. That's an excellent point. One of the things that I always look at within the perspective of caring for a patient, especially in those that I suspect or I know have FH, and that is that it's a family affair. And so that what you're going to learn from them about their family, they then need to take back what they learned from you to their families. I make sure that all their children and their grandchildren, whatever, usually it's just children at that point, are tested for LDL cholesterol. Getting the pediatric world and the internal medicine world to really look at family history carefully, including high LDL cholesterol, is really critical. And that's sort of my major point, is that it's a family affair.
Yeah, absolutely. Okay, so next slide. Let's talk about what happens if we don't treat, and what you're seeing in your patient population. So if folks don't have their disease state under control, going back to that sort of time is plaque thinking, it's sort of like a ticking time bomb in a way. So talk to me a bit about what it means when folks don't have their condition under control, and the chronification, the impact on them and their families and their work, if you can.
Well, I think, as I said a little earlier, the economic, the social, the emotional, and the physical repercussions of having poorly controlled cardiovascular risk factors are huge. It certainly does not help to have risk factors that are not well managed in light of anyone, which is every single one of us who are at risk for cardiac disease. So again, risk factor management, utilizing community-based interventions, cardiac rehab programs, nutritionists, smoking cessation experts, whatever you can find within your community, And then, of course, the underpinning of treatment, in particular for FH, is medical management, so that all of the medications available to us today, either in conjunction or by themselves, we should never give up on getting that LDL down to the ideal or goal level for every patient. And it does take time. It takes a lot of work, and it takes patients really taking on the same amount of interest in their prevention that you have. So again, translating prevention to the patient and working with them as a joint team.
And it sounds, you know, we talk about the relationship between a provider and their patient. What do you worry about when your patient leaves the room? Can you talk a bit about what, yeah.
I'm sorry. Go ahead.
Yeah, go ahead. No, go ahead, please.
My biggest concern within that exactly the question you asked, that is, what do people do when they leave the office? My concern is both adherence to new medication therapies and adherence to chronic medication therapies. What we're talking in this world right now in terms of elevated cholesterol, in particular FH, is a lifelong commitment to medical therapies and lifestyle. And that's a tough one. Chronic illness is something that nobody wants, that is really hard to get patients to take on as, this is kind of who I am. I am a healthy adult, I have FH, but I know how I can manage it. So helping to be sympathetic with adherence and compliance, but giving them tools such as tracking medications, tracking side effects, regular communications, getting their labs done regularly so they can see success. Because you don't basically feel success with lowering LDL cholesterol unless, of course, you avoid a heart attack, which you're not going to know because you're avoiding it. So we try to find a way to create success.
That's the next slide. That kind of gets us to our last point, which is access to treatment being the key. We just have a quick minute left, but you know, we think of employers as the consumers of healthcare. They're making important decisions for their workforce and patients, but what do you want them to know about what patients and providers have to deal with on issues like prior authorization? So let's say you, as a clinician, you have decided a course of treatment with your patient and they're experiencing roadblocks. What does that mean for them? And you just spoke about adherence. What does that mean for the management of their disease?
What it means is that clinicians need to take a much more intensive and active role in prior authorization. When you see patients who are on medications that you know their insurance company requires a prior authorization for, you have to act immediately. Once they leave the office, there should be a process in place for that prior auth to be managed and the communications back and forth with the insurance companies, because sometimes a single prior auth request doesn't go through and is not approved. So you have to hang in there until it actually is completed. And so that takes a real commitment on the part of the office in conjunction with the patients to make it happen.
Yeah. Well, thank you, Kathy. We're just about up with our time. Your perspective has been so valuable today. And I think this is a great segue to our next speaker, John Wylam, who's going to talk a bit about cost-effective benefits that improve access to care. John?
Thanks, Lindsay. Hello, everyone. My name is John Wylam, and I serve as staff attorney for AIMED Alliance. On today's presentation, I'll be discussing the importance of employee health benefits and ways to ensure that your employees have access to quality health care. So let's get started. First, let's review the problem. 31 million Americans are underinsured because their health plan has high deductibles or because their health plan's cost-sharing requirements are too burdensome. This means that when they try to access healthcare, there's a chance that they'll be unable to because the costs are too great. In a situation like this, a person's health insurance policy does not adequately guard them against the financial risk of getting sick, and they don't get much value out of the money they're spending on premiums. One reason that people are underinsured is because they're enrolled in a high deductible health plan. These plans' high deductibles force enrollees to spend a significant amount of their own money on covered health expenditures before the plan will cover a greater share of healthcare costs. These plans might be an attractive option for enrollees who want to spend less money on premiums and expect to have low healthcare utilization through the year. However, they're less attractive to enrollees who need comprehensive coverage of treatments and services and who expect to utilize healthcare more frequently. 70% of employers offer these types of plans, while 39% of employers only offer these types of plans. If an employee can only choose among high deductible health plan options, they will not be able to select more comprehensive coverage, which might be more appropriate for them. So according to a survey last year, 44% of individuals reported not being able to access the healthcare that they need because of the cost. The prevalence of high deductible health plans could be contributing to that trend. And the next point I want to emphasize is that cardiovascular disease is the leading cause of death in the US, and it continues to become more prevalent. Women in particular are at heightened risk for cardiovascular disease. So without access to comprehensive health coverage, people are unable to receive diagnosis or treatment for cardiovascular conditions, which increases the likelihood that their conditions will escalate and become more difficult to treat. This can lead to greater healthcare expenditures in the future. Employers can play a role in addressing these issues by ensuring that they offer comprehensive health benefits to their employees. Next slide, please. Patients with cardiovascular disease or those at risk of developing cardiovascular disease need access to certain types of services, which often require access to specialists like cardiologists. And we'll discuss those specific needs on the next slide, but the point I want to make on this slide is that different types of health plans will offer access to specialists to varying degrees. You'll want to make note of these differences when selecting which types of plans you'll be offering your employees. So there's a few displayed here on the screen, and I'll walk through those for you. An HMO will only allow enrollees to see in-network providers, and it will require a referral to see a specialist. However, the trade-off is that the plan will feature lower premiums and deductibles. A PPO won't require referrals to see a specialist, but they're often more expensive. Exclusive provider organizations are like HMOs, but they don't require a referral to see an in-network specialist. And a point of service plan will require a referral to see specialists, but enrollees will be able to visit in-network and out-of-network providers. So what I want you to keep in mind here is that these different styles of coverage will be more appropriate for your employees based on their expected healthcare utilization and how often they expect to visit specialists. To ensure that your employees can access the services that they need, it's best to offer a variety of health plan options so that they can select the style of coverage that's best for them. Along with the type of plan, health plans often include policies that limit or restrict an enrollee's ability to access treatments and services. These restrictions are often used as a cost containment measure to reduce overutilization of healthcare or unnecessary utilization of healthcare. As I mentioned in the last slide, patients with cardiovascular conditions require access to treatments and services like those listed on this page. Many of these can be expensive, which increases the likelihood that patient access to them will be restricted, even if they're medically necessary. The most expensive items on this list include specialty medications, laboratory diagnostics, and imaging diagnostics. There are many types of access restrictions that health plans use to restrict access to healthcare treatments and services. And the first one we're going to go over is step therapy. Step therapy occurs when a patient is prescribed a medication and the health plan requires them to try a different medication before allowing them to fill the original prescription. Oftentimes, this is not in the patient's best interest because the substituted medication might not be appropriate for them based on their individual characteristics and treatment plan. This creates a delay between when a patient is prescribed something and when they're able to access it, which can be detrimental to their health. Step therapy inserts the insurer into a prescribing decision that should be made between a patient and their doctor. On the screen is an example of how step therapy can negatively impact patient health in the context of a cardiovascular condition. PCSK9 inhibitor medications are newer and more expensive, so they're often subject to step therapy. However, they can effectively lower a patient's cholesterol. There could be situations where a PCSK9 inhibitor is the only effective way for a patient who is at high risk for a cardiac event to lower their cholesterol. In a situation like this, every moment that they have high cholesterol places their health at risk. If this patient is prescribed a PCSK9 inhibitor, but their insurer requires them to try a different medication before being allowed to access the PCSK9 inhibitor, they could suffer adverse health consequences. There could be instances where a patient has already tried the substituted medication and knows that it will not be effective, but they're forced to prove that to the insurer by trying it again. For example, a patient with atherosclerotic cardiovascular disease or familial hypercholesterolemia might not having access to the PCSK9 inhibitor when other options have failed places them at high risk for future cardiovascular events. Next slide. There are some legislative developments on this slide regarding step therapy, with some states that have enacted laws in the past year that regulate the use of step therapy and the introduction of a federal bill in Congress. I just want to mention that most of you will probably not need to keep up with state law on these topics because large employers are subject to ERISA. But if you are a smaller employer that sends your employees to the marketplace to obtain health coverage, these laws could impact your employees. On that note, the Safe Step Act that was introduced in Congress will impact employers subject to ERISA because it amends that law. If enacted, this law will require group health plans to provide an exceptions process to step therapy, where enrollees can request to be exempt from the step therapy process if certain conditions are met. There are other ways that step therapy protocols can be regulated to protect patient health, which includes defining circumstances where step therapy protocols can automatically be overridden, requiring health plans to utilize clinical practice guidelines when developing step therapy protocols, and preventing health plans from requiring step therapy when a patient has already tried and failed on the substituted medication. Next slide. The next access restriction that I'll review is called prior authorization. Prior authorization occurs when a patient is prescribed a treatment or service, but they're unable to access it until they receive approval from their health plan. This creates an additional hurdle between patients obtaining a prescription and being able to access it. This can create care delays, again, that can compromise patient health outcomes. Obtaining a prior authorization can take days or weeks, and this is valuable time for patients. Once a prior authorization request is submitted, a health plan could request additional information from the provider, which can create a lengthy back and forth that eats up additional time. Next slide. On this slide, there are some states listed that have enacted laws to regulate prior authorization practices. These laws focus on streamlining prior authorization requirements, which includes requiring health plans to standardize paperwork for prior authorization requests, requiring health plans to accept prior authorization requests electronically, and requiring health plans to use an evidence-based approach when requiring prior authorization. Next slide. And next up is non-medical switching, and this occurs when a health plan changes the coverage status of a medication in the middle of the plan year instead of during open enrollment. When this is done, patients are forced to either pay more out of pocket to access the same medication that they've been taking, or they're forced to switch to a different medication altogether. This practice is harmful to patients because they're unable to switch to a different health plan in the middle of the year. If health plans engage in non-medical switching, it makes it difficult for patients to know what will be covered through the plan year. In the context of cardiovascular disease, switching medications can be detrimental to patient medication adherence, resulting in treatment abandonment. This remains true for switches that occur between medications with the same active ingredient. And as shown on the screen, requiring a patient to switch between statin therapies can cause them to miss their treatment targets and places them at higher risk for a cardiovascular event. Next slide. There are 10 states currently that regulate non-medical switching practices, and hopefully more to come. These laws often prohibit mid-year formulary changes, or they require health plans to provide advance notice to enrollees before the formulary is altered. Illinois and Maine require health plans to allow patients to remain on their current medication if their provider confirms that it is medically necessary. Next slide. Quantity limits are probably the easiest access limitation to explain. For many medications, insurers will cover the average number of doses that patients need, but some patients may need more than that depending on their personal characteristics. So when coverage is restricted like this, some patients may be unable to achieve their treatment targets and they may resort to rationing their medications out, which isn't good. Next slide. So I want to show you how this works in practice. And on this slide, I have pulled some information from a health plan's formulary to show you what these access restrictions look like. This is a sampling of hypertension and insulin medications used to treat high blood pressure and diabetes. These are medications that patients need regular access to for them to successfully manage their health. Next to each medication in red are the access restrictions that each medication has before patients can access them. Some medications are subject to both prior authorization and step therapy, while others have quantity limitations or can only be accessed through a specialty pharmacy. When you work with an insurer to select a health plan that will be offered to your employees, you will want to pay attention to these types of access restrictions to gauge how freely your employees will be able to access the treatments and services that are prescribed to them. If coverage is too restrictive, you may want to discuss this with the insurer and attempt to negotiate a more generous coverage. Keep in mind that reducing these restrictions is a trade-off that could increase costs for you or your employees elsewhere. And this is another slide that features an example of access restrictions. This is one instance where there's 4 layers of restrictions that a patient would have to go through before being able to access one medication for the treatment of hypertriglyceridemia. The amount of time and energy that a patient and their provider would have to spend on satisfying the requirements of the access restrictions is enormous. And some of these requirements are common sense, but a healthcare provider is just as capable of making these determinations. Instead, the provider and insurer will have to go back and forth to establish that these requirements have been met before the patient can access their prescription. Next slide, please. Copay accumulators are the last cost containment strategy that we'll cover today. Many medications are prohibitively expensive for patients, even when they are just responsible for a portion of the medication's total cost. To help patients access their medications, organizations like charitable patient assistance programs or pharmaceutical manufacturers themselves offer financial support to patients to help them afford their out-of-pocket costs. Some of this financial assistance is limited to the patient's deductible, which would allow them to continue accessing the medication after the deductible has been reached. And insurers have historically accepted this money and counted it towards the deductible and maximum out-of-pocket limit, but recently insurers have begun excluding the value. And that means that once patients may be surprised to learn that once their deductible has been reached, they have exhausted their financial assistance. And once that financial assistance has run out, they might not be able to continue taking their medication, which causes them to ration out their treatment or stop taking it altogether. Patients taking newer, more expensive treatments are more likely to experience this issue. And so I just want to point out that among those medications that are eligible for financial assistance, 51% of them do not have equivalents. So if a patient loses access to one drug that they need, they might not have any other options. Next slide. Copay accumulators are particularly problematic for patients in high deductible health plans because they're unable to reach their deductible without financial assistance. Once their financial assistance runs out, their medications become unaffordable. We've seen a trend of employers continuing to adopt copay accumulator policies in their health benefits. And according to a recent survey, 17% have already adopted them, while 56% plan to do so in the next 2 years. We commonly see health plans featuring these policies with vague language that fails to adequately inform enrollees about the existence of the policy and how it could impact them. Even worse, some plans use misleading language, or they don't even mention it at all. Next slide. This slide includes some legal protections for enrollees who could be subject to a copay accumulator program. And I urge you to be mindful of these protections if you choose to adopt a copay accumulator policy. The ACA includes a cost sharing limitation, which a copay accumulator could violate by requiring an enrollee to pay more out of pocket than is allowed. The ACA also includes non-discrimination and pre-existing condition protections, which a copay accumulator could violate if it's only applied to certain conditions. And the ACA also requires summaries of benefits and coverage to use plain language, which a copay accumulator could violate if it uses overly technical or misleading language. There's also some unfair trade practice laws that a copay accumulator could violate, in addition to the Federal Trade Commission Act, if there's a lack of transparency or notice regarding the policy change. ERISA contains some fiduciary duties that health plan sponsors must abide by, which includes a duty to disclose important plan terms to enrollees and a duty not to mislead enrollees. And so employers could fail to satisfy those duties if they use misleading language about the copay accumulator policy. Earlier this year, the federal government had issued a rule that would allow health plans to exclude the value of financial assistance from an enrollee's maximum out-of-pocket cost and deductible, but they pulled that rule back and didn't implement it. So we're hoping to see a uniform policy enacted in the near future. So there's 4 states that have enacted laws that regulate copay accumulator policies, and we hope that additional states will enact laws regulating these policies in the future. Next slide, please. Regarding other types of access restrictions, there's other legal protections available to enrollees. So if used unreasonably, the ACA or state and federal unfair trade practice laws could provide a remedy. Some restrictions like non-medical switching could be considered a breach of contract and the breach of duty of good faith and fair dealing. So the publications listed on the screen that I hope you'll review and are included with the resources on this webinar. And you can access these through the resources page on the webinar page. So now that we've covered all of that material, you might be asking yourself what you can do as an employer to address some of these problems. We encourage you to provide comprehensive health coverage to your employees, which could include offering many different levels of coverage so that employees can decide for themselves how healthcare costs should be broken down. Additionally, we encourage you to create an opening and welcoming environment where employees can discuss their health needs without the fear of being stigmatized or discriminated against. This will help you understand their health so that you can provide coverage that is most responsive to their needs. Choose your health plan carefully and spend time negotiating with the insurer over specific access restrictions that you find unreasonable. Offer services to your employees to help them successfully manage their health and to help them enroll in the health plan that's right for them. Next slide. Additionally, ensure that the plans you offer are ACA compliant and cover all essential health benefits. While you may not be aware of your employees' specific health needs, it's probably safe to assume that some of them are managing complex health conditions that require routine access to healthcare. Be mindful of this when selecting the types of plans that you will offer your employees by offering some that are tailored towards people who expect to have high healthcare utilization. Offer several plan options so that patients can choose how their health benefits package works. Negotiate over unfavorable terms or those that you think could create issues for your employees. Next slide. I'll close with the recommendation to consider offering health plans with an open formulary, which provides coverage for all medications at different cost-sharing levels. This helps ensure that your employees will not lose access to a medication simply because their insurer has chosen not to cover it. Also, ensure that you have an appeals process in place for employees who need to work outside the health plan's coverage framework when it's medically necessary. And ensure that the appeals process is streamlined and offer it to assist your employees go through the process when necessary. So that's going to close my presentation on health benefits and some recommendations for employers, and I'll turn it back.
Thanks. So now we're going to have Dr. Gospel speak. So Dr. Gospel, take it away.
Thanks so much. Appreciate the opportunity to present. I'm Ron Getzel. I'm Vice President, IBM Watson Health, also Senior Scientist at Johns Hopkins Bloomberg School of Public Health. And my focus is much more upstream on prevention, primary prevention and secondary prevention, focused on things that employers can do to improve the health and well-being of the workers before they become patients. Next slide. So the problem that we as a society is trying to solve is figuring out how we can spend less money, and I say here on sick care, not on health care, because health care means that you'd be doing something to get people healthy, but really the entire healthcare system, as it's called, is focused on treating people, managing their conditions after they're already sick. So we are spending, and these are actually updated figures now, $3.6 trillion a year as a country on health care, and that's over $11,000 for every man, woman, and child in the country. And over half of that is being spent by employers and by consumers. Next slide. And we know that about 90% of all healthcare payments are devoted to the treatment of people with chronic mental and physical health conditions. And so if you ask the question, what can I do about this? Here's what the CDC recommends. Quit smoking, eat healthy, get regular physical activity, don't drink too much alcohol, get screened, get enough sleep, know your family history, and then make healthy choices in your school, work, and in the community. Next slide. The bottom line is that the vast majority of chronic disease can be prevented or better managed. 80% of heart disease and stroke, 80% of type 2 diabetes, 40% of cancer could be prevented if only Americans were to do three things that your mother and grandmother always told you to do. Don't smoke, eat healthy, and get in shape. Next slide. So it's easy, and this is really not the end of the story. Next slide. Because we're not doing that, obviously, as a society. And not only that, but we're spending the majority of our waking hours at work. Out of 24 hours a day, we sleep about 7.5 hours, but we're at work about 8.5 hours. So much more time at work, and why not take advantage and leverage that opportunity where you've got a captive audience. Next slide. Poor health costs money, but when you think about it, it's not just direct medical costs. There's a significant spillover into absenteeism and work loss, presenteeism, safety issues, all of which are affected by modifiable risk factors. Next slide. So we've done a series of what we call top 10 studies where we look at total spending by employers on a per capita basis. This is from our market scan normative database. And if you go up this slide, you see that the most expensive conditions are angina, hypertension, diabetes, low back disorders, AMI, heart attack, COPD, and so forth, most of which have a lifestyle attributable fraction associated with them, meaning lifestyle plays a big role in having these conditions. And this slide shows that it's not only direct medical costs, but also absenteeism, disability, which adds to the direct costs. Next slide. And if you bring in the bigger picture, that is, if you think about people who are actually physically at work, so they're not absent, they're physically at work, but they're not functioning at an optimal level, something called presenteeism as opposed to absenteeism. They're there, but they're not performing at 100%. And you can see that in many of these cases, these are another top 10 conditions, things like hypertension, heart disease, diabetes. Presenteeism actually outweighs direct medical costs in this overall study by a factor of 2 to 1. Next slide. We've conducted a series of what we call HERO studies, Health Enhancement Research Organization studies. In this study, where we linked 10 modifiable health risk factors to future healthcare spending over a 3-year time horizon. Next slide. We looked at the 10 risk factors and then lined them up and said which are the most expensive risk factors. It turned out actually that depression was the most expensive individual risk factor, that if people were depressed, and they told you that on a health assessment, they'd be about 50% more expensive than people who are not depressed, even when you control for the other 9 risk factors. Next slide. The thing is that when you look at these 10 risk factors, next slide, and you look at the prevalence of the risk and the cost, in this case, again, depression being the most expensive, next slide. But there are many more people who have obesity and many more people who are physically inactive. So next slide, when you consider the prevalence of the condition as well as its cost, it turns out that obesity, physical inactivity are actually more expensive on a per capita basis than is depression. Next slide. And these are the results from a multi-center study sponsored by the National Heart, Lung, and Blood Institute, looking at obesity rates across the country, and then looking at people who are obese versus a normal weight or overweight. And in each case, people who are obese were more expensive in terms of doctor visits, emergency room visits, hospital admissions, absenteeism, and presenteeism. Next slide. So scratch your head and say, now what? Next slide. Well, the now what is what employers can do as a result of evidence-based comprehensive workplace health promotion programs, also known as wellness programs. This is a systematic review done by the CDC, the Community Preventive Services Task Force, published about 10 years ago. We reviewed 86 studies. And next slide, they found that these programs can have a strong or sufficient impact on modifiable health risks. These are behavioral risk factors like diet, physical activity, tobacco use, and seatbelt use. Next slide. Also, strong evidence that these programs can have a positive impact on blood pressure and cholesterol. Next slide. And also can have a sufficient or strong impact on economic factors, things that matter to employers like healthcare use and worker productivity. Next slide. When you think about it, what you're hoping to achieve is a positive return on investment, which is untenable really in all of healthcare, with a possible exception of workplace health promotion prevention programs. To get there, though, you do have to climb this ladder and have high awareness, high participation, give people the skills they need, change their attitudes about their own health and employer offerings, get them to change their behavior, reduce their risk for disease, lower utilization. If you do all those things right over a 3 to 5 year period, you may be able to achieve a positive return on investment. Next slide. And there's literature out there that has shown that these programs can generate a positive ROI, somewhere around 3 to 1 for both medical and absenteeism. Next slide. These are examples of studies we've done over the past couple of decades that have looked at the health and economic impacts of workplace programs at large corporations like Johnson & Johnson and Dow Chemical and Procter & Gamble and Citibank. Next slide. Okay. However, my advice is that an ROI of 1 to 1, that is $1 saved for every $1 invested, is good enough. Next slide. If you're able to put in place evidence-based health promotion programs that can achieve population health improvement. Next slide. Our new research is focused on organizational health. Next slide. We published a study in February of 2017 with the American Heart Association where we asked the question, what factors in an organization, how healthy is an organization, and can the health of the organization be correlated with things that are important to employers, like the risk profile of their population, the prevalence and cost of cardiovascular disease. Next slide. So essentially the question was, what's the relationship between organizational health and individual employee health? Next slide. We accessed our very large normative database at MarketScan, got employers to complete surveys, ended up with over 300,000 individual workers that we could tie back to the organizational health metrics that we collected. Next slide. These were the risk factor definitions developed by the American Heart Association as idyllic. These are what it is that we're aiming to achieve from a healthy population. Next slide. And then we looked at the risk profile of these employers and found out that they actually had a lot of risk factors. Over 70% had unhealthy weight, poor diet, 2/3 of high blood pressure, half of the population physically inactive, about a quarter with high cholesterol and high blood glucose. The only good finding here was about 5% tobacco users. Next slide. We then connected the dots and we looked at organizational health metrics overall and by specific category. I'm not going to go through all the different categories, but looking at leadership commitment, organizational policies, strategic communication programs, engagement practices, community relationships, measurement and reporting, and found that by and large, the greens showed positive associations between good scores in these organizational health metrics and a lowering of employee risk profile and disease prevalence. Next slide. We followed up with other studies sponsored by the Robert Wood Johnson Foundation under the banner of Culture of Health. Next slide. We did some formative research going out and looking at those companies that have exemplary programs, many of which have won the C. Everett Koop Award. Next slide. These were some of the companies that we visited. Some are large name recognition companies, but then some are quite small, actually, just a few hundred employees, and some with manufacturing sites around the country. Next slide. And we came up with our top 10 list of those factors that really make a difference in influencing employee health and wellness, starting at the top with a culture of health, and essentially making sure that a culture of health, which is supported by senior and middle management, is communicated on a daily basis to all workers. And then down at the bottom, item number 10, ongoing measurement and evaluation of these programs with a feedback loop. Next slide. In this study and in about 6 other studies, we've also looked at stock price. The idea is to capture the attention of the chief financial officer at these companies. Next slide. For example, we studied over a multi-year period companies that won the C. Everett Koop National Health Award and compared those companies' stock prices to the S&P 500. Next slide. These were the companies that have won the award going back to 1999 through 2014. Next slide. And what we discovered was that the S&P 500 for that period of 2001 through 14 had doubled in value, return on investment of 105%, but these 26 companies that had won the Koop Award actually had tripled in value. So you can think about this as an ROI of 3 to 1. Next slide. In terms of what you do and how you follow best practices, there's a great website that the American Heart Association has put in place called the Workplace Health Playbook. Next slide. And the bottom line is that these workplace health promotion programs that are focused on primary and secondary prevention work if you do it right. You can find that they produce good financial outcomes, including in many cases a positive return on investment. You want to make sure you put in place evidence-based programs that affect population health. And then third category is what I call humanistic outcomes or value on investment outcomes, improve functioning of the workforce, improve productivity, attracting and retaining top talent, getting people engaged in their workplace, demonstrating corporate social responsibility, and enhancing the company's reputation. And with that, I will turn the floor over to Ryan. Thank you.
Thank you, Dr. Getzel. Hi, everyone. Good afternoon. My name is Ryan Googe, and I'm the Executive Director of the Partnership to Advance Cardiovascular Health, also called PATCH for short. Next slide. PATCH is a coalition of patient advocacy and clinician organizations. We're organized as a C4 nonprofit. All of the groups that are either a member of our organization or that we work with or have strategic partnerships with are listed here on the screen. You'll see AIMED Alliance and the Alliance for Patient Access there. Basically, what PATCH does is advocate for cardiovascular patients and patient-centered healthcare policies when access to FDA-approved clinician-prescribed therapy might be compromised. Next slide. What I wanted to just cover real quickly today is a story that's been really driving a lot of the health policy conversation in the cardiovascular space over the course of this year that was published this summer in the Wall Street Journal by Betsy McKay. It's an important story because you don't often see such focus on heart disease and stroke in the mainstream media like this, at least this high profile. But the thesis of this story was that after about half a century of progress fighting heart disease, scientists and clinicians had cut the rate of death from heart disease and stroke by about 70%, which has been one of the most incredible medical breakthroughs, in the course of American medicine. And this can be accounted for smoking cessation programs, dietary changes, advances in medication procedures. Those all account for that massive decline. But the crux of the story was that something has happened since 2011, and that rate of death from heart disease and stroke has fallen only 4% since 2011. The reporter, Betsy McKay, talks a lot about the fact that certain demographic and age cohorts are actually seeing the rate of death go up from cardiovascular disease. And this is actually eclipsing a lot of the gains that we've made in cancer and other disease states as well. So the conclusion is really that we're kind of at a crisis or a crossroads in America when it comes to heart disease and stroke. This has driven a lot of conversation at the policy level, both from Congress but also state legislatures. Next slide. And these trends have been talked about for some time in this cardiovascular space. In fact, the National Forum for Heart Disease and Stroke Prevention published a report on this saying basically the same thing a couple of years ago. And I'd encourage you to read either the Wall Street Journal article if you have time, or look up this report from the National Forum. This is important from a health policy level for employers, agency directors, health plans, Medicare, Medicaid, because as we've heard from Kathy Berra and Dr. Getzel, heart disease is expensive. It's expensive for employers to manage. It's expensive for the health system to manage. And actually, more than often than not, it is associated with another comorbid disease state that's also extremely expensive to manage. So the question then becomes, what is this inflection point in the data? What's the cause for it? Well, Dr. Getzel talked a little bit about this, and the two major drivers are diabetes and obesity. Next slide, please. But one line in this story really struck me and strikes, I think, at a lot of clinicians, and I think that Kathy Berra can talk about this a little bit in the Q&A. But it's that here that Betsy McKay says, heart experts say they need new tools and approaches because today's CV disease patients differ from those of past decades. But the question is, and this is what John got at slide, is how does policy prevent access, and can patients get access to these new treatments or tools at the end of the day? And as John went over, there are a number of different policies that affect access to these therapies, and I won't go through them again, but you see them on the screen here. You have prior authorization, step therapy, non-medical switching, so on and so forth. Next slide, please. So I want to give an example that kind of shows the real-world implications for policies that affect patient access to prescribed approved therapy. And this is just one example in the cardiovascular space. There's many that we can talk about. I know that Kathy and others can talk about many instances where prior authorization or so on and so forth get in the way of patient access. But we've heard today mentioned PCSK9s, which are an injectable biologic medicine that bring down really stubborn high cholesterol for patients, particularly those that have a condition called familial hypercholesterolemia, which is basically genetically high cholesterol. When these medications came to market in 2015, you can see here the rejection rate from the commercial health plans across the country was really, really high. So only about 30% of people were able to get access to a medication. Over the course of the next couple of years, the rate came down slightly, but not very much. Manufacturers, this is also after manufacturers cut the list price of the drug by about 60% at the end of last year, and we've still seen enormous pushback from payers to cover these medications. Slide. You can see here, actually, on our website at advancedcardiohealth.org, we outline by health plan and state, and also different risk factors and demographic groups, the rejection rates for this specific class of medications. So you can see what the rejection rates are in your state or by health plan that you may actually have a plan through. For an example, the state of Mississippi had complete block of these medications until earlier this year. And that's despite the fact that Mississippi has some of the worst rates of cardiovascular disease and death in the country. Slide. So the real question we'd like to answer is, like, what is the result of these kinds of policies? What happens? Well, the Familial Hypercholesterolemia Foundation actually published in a peer-reviewed journal at the American Heart Association called Circulation that high-risk patients had a 16% increased risk for a cardiovascular event when their PCSK9 inhibitor was rejected by their health plan. Individuals who did not fill their approved prescription, so they had a really high copay, for instance, had a 21% increased risk of cardiovascular event. And individuals with FH and established cardiovascular disease had more than 5 times the risk of others in this study. Insurers rejected 2/3 of their prescriptions. So we're talking about people that can't, they have genetically high cholesterol, they need this medication, and yet 2/3 of them cannot get it. Again, I present this as just an example of the kind of real world implications of these policies. There are a number of other medications that we could talk about, but PCSK9 has been one that's been really talked about a lot in the cardiovascular and health policy community. So I just wanted to bring that up today. I'll pass the mic. Thank you.
Wonderful, thank you. Well, we're now going to turn it over to Alan.
Thanks, Ryan, and appreciate everybody's comments prior. I'm going to bring up the rear and try to tie it together with biometric screenings. Most people are familiar with on-site biometric screenings, and that can provide valuable data to your employees. So when we're talking about earlier about the high deductible health plans and how that can create kind of a hole that employees can end up in, this can mitigate or at least provide some good information to your employees to help manage or identify those people at risk for diabetes, cardiovascular disease, hypertension, and obesity. So typically we'll go into an employer group, or there's a lot of other companies in the industry that do this type of service, or sometimes a lot of employer groups send them to their physician, which is good in that you provide that, facilitate that relationship with their primary care physician, which predominantly men have a lesser acceptance of using their primary care physician on a regular basis. So you're encouraging that behavior, or there's a lot of other options available now where they can go to a pharmacy that has a clinic, and we can collect that data, or other providers out there can collect that data on the behalf of the employer group and use that data to fine-tune their health plan and to address areas that they may need to address, such as cardiovascular disease. Next, you can go to the next slide. So we took screenings back in 2008 that we provided to various employer groups all over the country. So there's some data that Ron had that was very informative, and our population may not be the exact same mix that Ron had in his data that he outlined, but this kind of outlines, a lot of people have normal, but if you look at 43% had normal blood pressure, that means 50% had some borderline or high blood pressure. So doing the screenings, you help educate them on their values, and you can easily introduce them to other programs that the employer may offer. It could be a disease management program. It could be a health coaching program that the employer is offering. A lot of times there's EAP programs that can tie in that are underutilized typically with employer groups. So work with the employer. We typically work with the employer groups to help kind of create that bridge to those other resources that may not be known to the employees at those screening events. Next slide. I kind of outlined this a little bit, but really understand the data you're getting when you do screenings and help them drive a positive behavior. I think behaviors are the hardest things to change, and a lot of times focusing on putting things into small chunks and helping your employers kind of achieve success in some small ways and build upon those small successes eventually get you to the end point of what you want to do and help manage their chronic health conditions. Because as Ron said, most of our healthcare costs in some way or another can be controlled by modifying people's behavior. And a lot of people, do not think in those terms that, a lot of these healthcare costs and changing the behaviors so that we have a positive effect on their medical costs. Presenteeism, as Ron pointed out, is a big thing that we sometimes don't focus on. But people can be at work, but they're not really effective at work, and so we need to address those things. And using screenings, whether it's on-site or using other alternative ways to collect that data and to educate, are the good steps. And I think there was a good slide that Ron had that screenings are not necessarily the end or the beginning of a wellness program, but they're a good piece of that needs to be utilized well. And so it's important to look at that data and look at what it's giving you, and then use that to your advantage to help drive your wellness program and to drive ultimately return on investment in various ways. And I don't know if there's much more that I can say. Our next slide just talks about a specific example that, employees don't understand what real food is. And so we had a challenge that one of our employer groups that helped them in their place replace fake foods with real foods. So example we put here is for 6 weeks. Again, as I framed earlier, is that you want to put things into a small, achievable challenges or goals so that people feel like they're making subtle changes that are achievable rather than long-term. So replacing a bag of chips with a handful of almonds, something that is real easy to do, and it starts moving that needle of changing their behavior in a positive way. So those are good examples of things that we like to encourage, and using biometric screenings as a way to channel those changes. And if anybody has any questions, we'll catch up with that now.
Wonderful. Thank you so much. I want to thank all of our presenters. We have about a minute left, so let me see any questions we have. Actually, it looks like the only question is about certificate of completion. Yes, participants will receive certificate of completion. It'll be emailed to them. Let's see. We just got a question from Joe Maloney who said, is it true that long work hours increases the risk of CVD? Does anybody have the answer to that? Long work hours increasing the risk of CVD?
Certainly, high stress will do that, yeah.
This is Kathy Barra. I'd like to respond to Joe's question that I think there is a significant amount of data looking at stress and the relationship of stress and other lifestyle factors often associated with stress and the risk of CVD. And certainly long work hours, hard work hours, difficult work hours could be included in a particular formula so that perhaps there would be more smoking, there would be less good sleep, there would be more eating for whatever reason, and weight gain and lack of physical activity with longer work hours. So I think that's a great question that was proposed. And I would say there's probably enough data to say that it probably is it's a problem.
Okay, wonderful, thank you. It does look like we're out of time. I just want to thank all of our speakers today, as well as our sponsors, Amgen and Amarin. And if anybody does have any additional questions, feel free to email us at policy@aimedalliance.org. And thank you, everyone, for your time today. Have a wonderful afternoon.
Thank you.
On behalf of HR.com, I'd really like to thank our sponsors, AIMED Alliance and Alliance for Patient Access, and our speakers for this important information that they shared with us today. Also, thank you to the audience for joining. We will be sending you an email with your credit information. You'll also find the credits in your View My Credits page of your membership profile once the webcast has been archived. Your feedback is important to us. Please take a moment to fill out the exit survey that opened in a new browser page on your computer. This concludes our webcast. Enjoy the rest of your day.